again. So today we are going to talk an important topic, that is jaundice. It is also known as ectris because the whole body color will change into yellowish or pale color. So that's the reason we'll call ectris. So basically, why this happened? Because we have one thing, that is bilirubin. Okay, bilirubin level is increased in the body. So that's the reason the patient will have uh, yellowish face color, hands, nails, his conjunctiva. Okay, and second is urination, and stool will also be in the pale in color or yellowish color. Okay, so these are the things we can have to remember about jaundice. That increased bilirubin level in the blood is defined as jaundice. So basically, what will happen? We already know that there is red blood cells, RBC. Okay, RBC. What will happen in the RBC? We have hemoglobin. Okay, hemoglobin. Okay, hemoglobin carries oxygen. In the each RBC, we have four hemoglobins. The color of the hemoglobin is due to the ferrous. Okay, due to the iron. Okay, so it will carry the oxygen and it will release the oxygen at cell. Okay, so this is the function of RBC, hemoglobin, ferrous, everything. Here, what will happen? So we have to break down the RBC. So RBC lifespan is very nominal. Okay, 60 to 90 days. Okay, sometimes less than 60. Okay, this is the life cycle of RBC. Then it will go the breakdown period, where it will have breakdown period. Where it will break down in spleen. Spleen is the graveyard of RBC. Okay, but here what will happen? So RBC will break down, then hemoglobin will release, and in the hemoglobin, hem is also utilized. Okay, but here we have the albumin, globulin, albumin. Okay, albumin. Albumin here, this is a one of the protein substance, bile pigment. Okay, it cannot be break down in the spleen or any other, we will call it reticuloendothelial system outside the uh, liver, outside the spleen. Okay, whenever breakdown happens, we will call reticuloendothelial system. So what will happen here? It have to be breakdown. So it have to be breakdown. It will go, and it have to be excrete from the body. Okay, excrete from the body, but it cannot be excreted directly through the kidney. Okay, with the help of urination. Okay, so basically it will go to the, where it will go? It will go to the liver. Okay, it will, what will do? It will illuminate. It will compress the. It will change its phases to excrete from the body. Okay, so here it is the function of the liver to eliminate the bilirubin. It is the converted form. I will show you the picture here. You can see that this is the HB releases from the RBC, in the RBC there is HB. HB releases and it will become hem. Okay. After that, it will become biliverdin, unconjugated bilirubin, and conjugated bilirubin. Here we have the last phase. Unconjugated bilirubin, it is unable to release from the kidney, so you need to conjugated bilirubin. Okay, who can done? It will the help of liver on. So it will come to the liver. What it will break down? It will make minimal so that easily it can be excrete from the body. Okay, so uh, what will happen then? It will excrete from two two areas. One is GIT, okay, and urinary tract, UT. Okay, so the bilirubin is excreted through bile and goes into intestine. So here I explained that in the liver we have the bile duct, we have the gallbladder here, and we have the common bile duct, we have the in the duodenum. So the the bilirubin will excrete in the from the way of bile, okay, bile, and goes into its intestine. We understand that in intestine, this bilirubin changes into stercobilinogen. It is a term we'll remember as SP, stercobilinogen. Okay, it will convert. Okay, its large part reabsorbed by intestine and goes into portal circulation and again comes into liver and re-excreted into the bile. It's called enterohepatic circulation of bile pigment. Okay, I think it is very difficult to understand, but little part if you understand, it is okay, no issues. But the concept you need to understand, that is very important. So, so here intestine will, along with the bile, it will come into the intestine. Okay, it will convert into steroglobinogen. Okay, and again the intestine will reabsorb and it will come into portal vein and again it will go into the liver. Okay, so this is not excreted completely. Okay, it is not excreted completely, but gradually it will excrete it. This is the thing you have to remember. It is through gastrointestinal tract. Next we have the urinary tract. This is very important. This is small part of, that is SB. We know that SB, stercobilinogen. Okay, this is 4 mg on the daily, passes in blood stream and filtered by kidney. Okay, and excrete in urine is called urobilinogen. So it is excreted by urine, which we call urobilinogen. Okay, this is the excretion of bilirubin in other forms. So that is the only process it will release. Okay, the thing we have to remember. So this is the function, the overall body normal function or normal metabolism of hem. Okay, hemoglobin. Okay, so this is the daily process. If it is okay in the normal level, excretion is in normal level, nothing will happen. If it is in higher quantity, how it is increased level happen? There are two or three phases, 3 to 4 phases due to the damage of liver cells. Okay, first is damage of liver cell. This is the thing. And second one is transport mechanism, any disturbance in the transport mechanism. Okay. Third is any conjugation. Already you discussed that conversion of the bilirubin in the gastrointestinal, it will become stercobilinogen. In the urinary tract, it will become urobilinogen. So any transformation or transformation area problem, GIT or UT problem, urinary tract. And fourth one is any problem in the excretion. It is directly based on urogenital organs, or we have gastrointestinal organs. Here, the conversion. Here, the excretion. Conversion problem or excretion problem. These are the four things where the problem occurs. At last, at summary, the problem is in the liver, the problem is the GIT tract, there is a problem in the urinary tract. Simple. Remember this. Okay. So let's discuss this. These are the causes. Okay, causes of jaundice. Any liver damage, GIT issues, or urinary tract issues. These are the three things you have to remember. But the jaundice will appear. We have two stages. We have the first stage is prehepatic, means there is a problem in these organs, but appearance or clinically we will have two things. Remember, one is prehepatic. We will call pre. There is no relation with the liver. It occurs. It increases in the bloodstream. It the problems itself in the bloodstream. We will discuss in detail. Okay. I will detail. I will explain in detail. Or we will call hemolytic jaundice. Pre-hepatic or hemolytic jaundice. First one is, second one is post-hepatic jaundice. Sorry, hepatic jaundice, second one. So in the jaundice, we have three types. Third one is post-hepatic jaundice. So we have pre-hepatic jaundice, hepatic jaundice, and post-hepatic jaundice. These are the three types of jaundice are there. So let's discuss all these three things. Primarily, first we discuss about pre-hepatic jaundice. But what is pre-hepatic jaundice? In this type of jaundice, usually present before liver, okay, means in the blood. The problem is in the blood itself. So what will happen here? The RBC are destructive, excessive destruction, excessive destruction of RBC is seen because of there are, if daily 12 10,000 to 15,000 RBC are destructive in normal range, but suddenly it is increased daily 50,000 RBCs are damaged. So then what happened? The hemoglobin will break down, then conjugated bilirubin have to be produced. So it means that due to the destruction, there are more chances of becoming bilirubin. Okay. In normal condition, liver can excrete bilirubin 6 times. Okay, more than the normal. Okay, before conjugation, bilirubin accumulates in the plasma. It usually appears in newborn. So hemolytic uh, or pre-hepatic jaundice is seen in newborn mostly. Okay, okay, newborn. This is the thing we have to remember. And in other cases like sickle cell anemia, okay, mismatch transfusion. So there is mismatch in transfusion. A group person transfused his blood to B group person, or AB group transferred to B group. Likewise, okay, mismatch. Newborn, sickle cell anemia person, or mismatch blood group transfusion. In that, the destruction of RBC will happen very fastly, very continuously. So, okay, what will happen? The serum bilirubin levels will increase. So, what will happen? The bilirubin levels increases. So, here what will happen? stercobilinogen will appear into the stool. Okay, SB will appear in stool, and we have the excretion will also be done in the kidney. So what will happen? Urobilinogen will increase in the urine. So that's the reason stool will seen as yellowish color and urine will seen as yellowish color, mostly dark or a deep yellow. Deep yellow color will seen. Okay, so in that the RBC level gradually decrease or suddenly decrease. The patient will have a high level of bilirubin. Okay, so this is a thing we have to remember. Okay, anemia, patient is seen in anemia because of RBC destruction will happen. So that's the reason RBC are low. So serum bilirubin level high. Okay, ESR also decrease because there is no RBC. So ESR, erythrocyte sedimentation rate will also decrease. Okay, so these are the things will indicate this is called pre-hepatic jaundice. Okay, next we have hepato hepatic jaundice. Second one is okay, hepatic jaundice. So what will happen in that? In this, what will happen? The liver cells. So due to the inability of transfusion of bilirubin or bilirubin is cannot be converted easily, or the liver cells are not able to convert the bilirubin. Okay, or or push the bilirubin into the bile duct. Okay, so what will happen? Unconjugated bilirubin, okay, it will reach to the liver and also it will not pass through the bile duct. Okay, what will happen? So the liver swelling is there. What will happen? Liver edema is seen. Liver edema is seen. What will happen? The gradually the liver will release those bilirubin outside and it will get into the blood plasma. This is very dangerous. Or sometimes septicemia will happen. Whole infection will spread all over the body. It will also called yellow fever because it is not converting bilirubin and it is not break down the bilirubin and is storing the bilirubin. What will happen? Liver will have the septic or infection. So suddenly it will the rise level of bilirubin will spread in the all the hepatic arteries, vein, and it will spread all over the body. And sometimes it will become septicemia. Okay, we'll also call yellow fever. This is also called as yellow fever. So this is very, very dangerous. Patient can die in this condition also. Next we have third one is post hepatic jaundice. What will happen in that? In that the jaundice blood and liver are healthy because blood in the RBC, okay, destruction normal level, liver also converting or it will break downing the bilirubin. All is well. Okay, but here problem is in the bile duct sometimes. The problem in the GIT or already tell. This is a problem in the urinary tract. So what will happen? This will obstructing to release of bilirubin from outside the body. So what will happen? The level of bilirubin increases. Okay, this will cause the body harmful. So we need to understand where is the problem and how to treat the this condition. Okay, so these are the things about uh, bilirubin levels and everything. So what are the clinical features? So we'll divide jaundice in two parts. Okay, because we have to talk about LFT here, very important. Okay, liver function test is the main diagnosis. uh, microbiological diagnosis, okay, or pathological diagnosis will give the correct value. So then only that's reason we'll talk about LFT in detail. So we have treatment part and diagnosis. After LFT only we can diagnosis. So there's the reason we will discuss tomorrow about jaundice in part 2. So let's revise something what we studied till now. So it is nothing but the hemoglobin, the hem part is very important. Okay, you can see in this image. Okay, RBC is released. Okay, RBC, then hem is there and converted into biliverdin. And here we in the biliverdin we have unconjugated biliverdin. It will go to the liver and liver will convert into conjugated bilirubin. Okay, then the small intestine, large intestine, and excreted from the body. And it will also go into the blood and it will filter into the kidney. After that, it will go to the urinary bladder and excrete from the urinary bladder. This is the simple thing. Okay. So if the bilirubin level increases, so what will happen? We have the problem. It may be problem in the liver. It may be problem in the GIT. It may be problem in the kidney. Okay. So we have three types of jaundice: pre-hepatic, hepatic, and post-hepatic. Pre-hepatic means it is a problem in the blood itself, means RBC is reduction continuously. Hepatic means there is a problem in the liver. Post-hepatic means a problem in the bile duct or GIT or any UTI. So there's the reason unable to uh, excrete bilirubin from the body. Okay. So I hope you understood about that. So pre-hepatic mostly seen newborn, sickle cell anemia, mismatched blood group. Okay. Post-hepatic, hepatic is very dangerous. It may be fatal or septicemia will happen. Pre-hepatic is a problem in the bile duct, GIT, and urinary tract. Okay. So tomorrow we'll discuss the clinical features, liver function test, and treatment. Okay. So any doubts, kindly ask.